Hi there, I'm Dr. Ahsen Nazir Ahmed. In this talk, we are going to talk about the hernias. Hernia is anything coming out of abdomen, mostly in a common term, and we have potential openings in the groin, around the umbilicals, and other areas where either the fat of the abdomen, or tummy, or the intestine can come out through that potential opening. It doesn't happen in all of us, but it happens in some of us. It can be by birth, presenting at a very early age, or it can be later in life due to overweight, lack of exercise, sedentary lifestyles. When these openings open up, which are potential spaces, when they open up, they let the intestine or the fat come into it. It's called as a hernia. In technical term, it is a abnormal protrusion of a viscus or part of a viscus through the opening of its contained cavity. The operations of hernia started many decades ago, and there was technological advancement and improvement in the surgical skills. So ultimately, it went on to be done by laparoscope, which is commonly called as a camera surgery or a laparoscopic or a laser surgery by a layman. Now, hernias can be groin hernias, which is inguinal or femoral, or they can be the ventral hernias, which can be between the chest and the umbilical, which is called as epigastric hernia, or it can be around the umbilical, which is called as a paraumbilical or an umbilical hernia. We are doing both open surgeries as well as laparoscopic surgeries. We have been doing these for almost last 15 to 18 years. The important concept is that mostly when people are not trained, not skilled, they tend to do an open surgery, that is without a laparoscope or a camera. But for trained personnel who have had the privilege, the God has been kind, God is always kind, but still, when people have been trained and they can do by laparoscopy the repairs of hernia, that's a much better choice. Smaller incisions, better recovery, less pain, less cost, and they go home to their office, to their work, they can drive, they can play around much earlier than when it is an open hernia or a larger incision. We are doing ventral hernia, that is paraumbilical epigastric through a laparoscope, usually a small port, 5 millimeters, 2 ports, and 10 millimeter, 1 port. That's all we need. We put a mesh from inside. Now, I would like to give you an important concept. If there's a boat and there's an opening in the boat and the boat is going in the sea, the water will start to come inside the boat. Now, there are two ways of closing this opening. Either you put a patch from inside the boat, or if you are skilled, you go into the sea and you put a patch from outside on the outer surface of the boat. Naturally, the patch from the outer side is more durable and better work because it will have the pressure of the water and it will not allow the water to come inside the boat. This is what happens in the hernia surgery. So for hernias, when you have a choice between open surgery or laparoscopic repair, you must always opt or choose the laparoscopic repair. Reasons are the same: less pain or almost no pain, rapid recovery, same day or next day discharges, and early recovery, going back to work, to office, to home early, doing normal daily activities in a better way. For groin hernias, we have two kinds of repairs. One is TAPP tapp and one is TEP tapp. Tapp is total extra peritoneal repair. In tapp, which for me is a better choice because the world recognizes that and the studies have shown that we don't have to fix the mesh or the network we put into the net we put into the openings, and it almost leads to no pain after the operation. Whereas TAP, TAPP TAP, total abdominal transabdominal preperitoneal, we have to fix the mesh. When we fix the mesh, sometimes there's a lot of pain. And these mesh are fixed by either a metallic or a plastic kind of a gadget known as a tacker. So for TAP TEP, TAP total external peritoneal repair, we do not use any tackers. I mean, I'm not using it, but still some people are still using it. But the international studies have shown when you are skilled, you have a skill, when you have done around 500 number of cases, and you have the results published, supported by the international studies, then you have this kind of an approach. Hernia is a common disease, and when we come across the patients, remember, spending for the cost of mesh or the tacker by going laparoscopically might sound a little expensive in the beginning, but considering the pain, the early recovery, less pain or almost no pain, and early recovery in a laparoscopic repair will benefit you more in the long run than it can in the short run. For ventral hernias, we must do laparoscopic both for epigastric as well as paraumbilical or umbilical hernias. When you go to a doctor or your surgeon, always ask them if they are skilled, can they do it? Because the studies done internationally have supported, have been convincing that the cases where laparoscopic repair can be done or should be done, should be done. There are few cases in which laparoscopic surgery for hernias cannot be done, but then they have to be explained to the patient why the doctor is not doing it.